Welcome to Behavioral Health Today, a Triad production. I'm your host, Dr. Graham Taylor. My guest today is Tracy Gilmore Nimoy. Tracy brings both lived and clinical experience to today's show, including difficulty conceiving, fertility, high-risk pregnancy, traumatic delivery, infant pregnancy loss, and pregnancy after loss. Tracy is a licensed marriage and family therapist and certified perinatal mental health professional. She works with individuals, parents, and families throughout their reproductive and family starting journeys. And she's become a fierce advocate of perinatal and reproductive mental health with the goal of supporting and empowering other women, individuals, and parents, as well as families. Tracy is a return guest to our podcast. And in our first show, we named and discussed the three, what we then called transitions, experienced in one's life within the context of Tracy's clinical focus. They include pregnancy, infertility, and postpartum. She shared with us some of the common experiences she hears from folks going through each of these transitions. It was a great show. And if you haven't had a chance to take a look at it or listen to it, go back and do so. You'll really enjoy it. Well, we're excited to have Tracy back on our show today as part of our clinician series, where we're going to be taking a deeper dive into the techniques and the strategies and the constructs around perinatal mental health and the unique ways that Tracy works with those that come to see her. Tracy, welcome back to our show.
Thanks so much. I'm so excited to come back and be here. Appreciate it.
Great to have you here. You know, as we set this up with this focus today, the perinatal and reproductive mental health, if you would, what is typically going on in the life of those that are walking in your office and coming to see you?
Yeah, it's a good question. You know, reproductive and perinatal mental health is a pretty broad spectrum specialty. And so what most people think of when they hear that is pregnancy and postpartum. And that is a great portion of it. I'm a little different in that I focus more on the subspecialties. So I do that. I do pregnancy and postpartum, but I really have a special place in my heart for pregnancy loss, infertility, birth trauma, donor conception, surrogacy, adoption. And so I'm really looking at the experiences that maybe not everybody is going to have. They're kind of entering it thinking, I'm going to be pregnant, I'm going to be postpartum. It's like they're expecting certain experiences to happen, and then it doesn't go as planned. And so while I do it all, I really focus on those sort of subspecialties.
I want to just highlight that because what you did so vulnerably, and we were so appreciative of it, was to share your journey in our first podcast. And without having to go over it today, I'm going to encourage our listeners to go back and take a listen to that because it was so powerful. And I think the vulnerability and the candidness you had, really the transparency in that podcast, I think invites people to recognize that it is safe to talk about this. It's important to talk about this. And there's a place and a way to do it that can be really therapeutic. So when folks are coming in and you have this focus, and especially typically, what are they walking in with? And how are you beginning to kind of assess, hey, what might we take a look at here and use therapy for in a beneficial way?
Yeah, well, I think a lot of this stuff presents as anxiety. And like even prior to something going wrong in a pregnancy, the feeling is anxiety. And oftentimes people will get labeled as being, quote, just anxious, like just an anxious pregnant person. And it's really common that a person will have a bad feeling about pregnancy and will go to the doctor, and the doctor will say, oh, this is just anxiety. And so that's a primary emotion. And now if we're talking pregnancy loss, then we're talking trauma. And how does trauma present? Well, it often presents as anxiety. I'm scared that this is going to happen again. I don't feel safe. It rocks the sense of safety. And so anxiety, trauma, depression, of course, if someone's losing a pregnancy, if someone can't get pregnant, if someone is in the midst of a pregnancy after loss or a high-risk pregnancy, they're going to be feeling sad. They're going to be feeling depressed. And so I would say anxiety, depression, trauma are kind of the way that these things present at the onset.
I know what you're describing right now is you're kind of normalizing and kind of universal, you know, this idea in therapy, we get to kind of universalize, if you will, that you're not the only one. And we can begin to kind of normalize that these are normal experiences given what you've gone through or currently in. Oftentimes I think about anxiety as the perception of a threat, whatever that may be. And the perception that I don't have control over that, or I'm not going to. And the key word in there is the lack of control. Exactly right. So the idea is that the key word in that is the perception. And I would imagine that a
Right.
lot of this is, I don't feel like I've got the ability to cope or manage with this. How do you start to
Yeah.
name for them and normalize depression,
Yeah.
anxiety is common within the context of this trauma? And here's how we're
Yeah.
going to lean into this.
Yeah. Well, it's such a good question because here's the thing is pregnancy, even when everything goes perfectly, is
Yeah,
anxiety provoking.
you bet.
It's an experience that happens in your own body. And what's unique about it is that there are two patients. There's the baby and
Mhm.
there's the parent who's carrying that pregnancy. And so not only are you focused on the carrier's health throughout the
Yeah.
pregnancy, but then, keeping this baby healthy and alive and safe. So most people are going to feel a normal dose of anxiety in pregnancy without any challenges. Now, if you throw in, okay, like your scan came back and there's something concerning, or your blood pressure is really high, or you have gestational diabetes, or
Mhm.
there's a history of a high risk pregnancy or a really tough delivery or traumatic delivery, it's not only anxiety, it's trauma. And what's different about trauma, even though it presents kind of similarly to anxiety, is that it's rooted in lived experience. Whereas like
Mhm.
anxiety might not be. It could be a catastrophic fear, right? It could be like, I'm scared that I'm going to walk into this building and all the elevators are going to break. And it's like, well, has it
Right.
ever happened to you before? No, it's never happened to me
Right.
before. That's an example of of anxiety. That's anxiety. I'm
Sure.
scared this is going to happen. And so you really have to be able to know the difference, because I can't treat trauma and the anxiety that accompanies trauma in the same way that I would treat anxiety like that.
Mhm.
I can't say, this is really unlikely that this could happen. Could it happen? Yeah, but it's highly unlikely, because when someone is coming to me and they've lost a pregnancy, I can't say to them, you're never going to lose another pregnancy. That doesn't
Right.
happen. So it's very different the way that I look at it when someone comes in.
And that sounds like an important starting point of, this is not just something in your head. This is not something that like
Yeah,
what if or could be, or
yeah,
this is something
yeah,
that's, I like what you said, rooted in
yeah,
experience. And this is real. And the
yeah,
perception is not just this good, this has happened and what's going to happen possibly this time. Tell me, when you're
yeah,
talking so far
yeah,
about, well, sound like you're talking more about women right now, holding that
yeah,
just for a second. If
sure.
there's a partner in the room with them, what are they
Yeah.
experiencing? What's the difference between the genders and their response to these things that are coming up? Anxiety, depression.
Yeah. So what I typically see, and of course everybody's different, what I typically see is that the non-pregnant partner feels like they have to be strong and keep it together. And
Mm-hmm.
the person who's pregnant or trying to become pregnant, like the focus is on them, which, makes sense, they're the patient. But in some ways, it creates this like relational divide, where
Mm-hmm.
then the person who's pregnant feels like, oh my gosh, my partner doesn't get it. They're just telling me to think positively and to stop being anxious. And then the other person feels like they have to be strong. And so they might be actually feeling that way, but they're not vocalizing it. And so, like,
Yeah.
and nobody checks in with them, at least not
No.
as much. Like, I remember just like in my own experience, and I'll give a quick Cliff Note version of, I
Please.
had a third trimester loss. And I was a therapist prior to that loss. And I went through the process and realized that nobody knew what to do or say to me. And very traumatic delivery that I almost didn't survive. And then following that, due to the surgeries that saved my life in that delivery, have had multiple miscarriages and infertility. So in my own experience, like nobody checked in with my husband. It was when
Mm-hmm.
they called him to check in, it was, how's Tracy? And I remember he just kept saying, I'm fine, I'm fine. Like, I don't feel anything. And then complete meltdown, a year later
Yeah.
of, oh, wow, this is really impacting him. And so I think because we aren't used to acknowledging the experience of the partner, it can go missed
Mm-hmm.
and it can create relational distress.
Mm-hmm.
And they need a lot of support to realize that, one, everybody has a different experience and it's okay if they don't align. But oftentimes, what I see is that it's usually the person who's pregnant that will grieve more openly and
Mm-hmm.
be more like dysregulated or expressive
Mm-hmm.
in those emotions, and the partner will be more stoic. And then with time, that person who's pregnant will learn how to regulate, and they won't be crying as much with time, and then the partner will sort of fall apart. It's like the
Mm-hmm.
over functioning, under functioning. When one person's functioning up here for the system,
Yeah.
the other one can kind of fall apart, and then it kind of switches as that person,
Kind of like
is
the
able to
delayed
function more.
response. It's such an
Yeah.
interesting piece because it's, let's just say the non-pregnant partner, the guy in this situation, let's say,
Yeah.
might be
Yeah. Or
wanting to be
women, if it's,
supportive. Yeah,
same
sure.
sex
Depends.
couple.
Yeah.
Yeah.
So let's say that
Yeah.
let's say the non-pregnant partner, in those cases, they want to be strong, and they want to hold the person up. And it
Yeah.
almost feels selfish that how can I express, what I might be going through if they're the ones that are, that are pregnant, and I'm just
Yeah.
trying to be here. And I could see where
Yeah.
they're not talked in or talked to
Yeah.
or checked in. But what a nice space I would imagine that
Yeah.
you're able to create for them,
Yeah.
the non-pregnant partner in the therapy, to say, hey,
Yeah.
let's not forget you.
Yeah. And I remember so clearly, like in my own experience, and then I see this in therapy all the time, where like, they get frustrated. They're like, I want you to be upset about this. Like, this is upsetting.
Right.
Stop pretending. And I remember my
Right.
husband used to just say to me, I need to be strong for you. And at one point I remember just like screaming at him, like, I don't need you to be strong. Like, I need you to be real. Like, what is
Yeah.
happening? Like, are you not depressed about this?
Yeah.
And I remember that was just like kind of the moment where he could just kind of like fall apart. And then he would share with me how depressing it was for him and how
Mhm.
painful. And I think what's important to mention is that there are differences in these processes. So the person whose body it is going to have the medical trauma and the
Mhm.
physical intervention and pain and recovery. The person who's the partner is going to have the added emotional trauma of witnessing their partner go through it.
That's tough.
So yeah, I mean,
Well,
it's
you talked about this idea of trauma. It's a lived experience, even,
yeah,
in vivo, in those moments. Trauma,
yeah,
experience outside the realm of normal experience. That's
yeah.
huge, and to watch that take place and to vicariously be a part of that. That is traumatic, isn't it?
It's so traumatic. Yeah. And to feel helpless, like
Hmm.
you can't do anything to help that person,
Hmm.
to make it better for them. Or to even like I hear a lot of partners say, like, I wish it was my body. I wish I could go
Hmm.
through the procedure or surgery
For
because
you.
like yeah, I mean, because that's the thing is it's not just like this is what's so unique about any trauma in the like reproductive space is that it's medical. There's a
Mhm.
medical procedure, usually multiple medical procedures. So it's not just like, okay, you had this traumatic incident and it's one incident, it's
Mhm.
multiple follow up. And then usually it's continued follow up if you're trying to get pregnant again. So it's like you actively put yourself back in a situation that will likely reactivate and trigger the trauma.
You
Whereas
bet.
with some other traumatic experiences, you can kind of avoid. You can say, like, okay, I had a really bad experience at this summer camp. I'm never going back to that summer camp.
Mhm.
But if the goal is to try to get pregnant again and you've experienced trauma, you have to kind of put yourself back into
You've
that.
got to go through that again.
Yeah, I mean,
Yeah.
even like something as simple as like going to the dentist can be really
Mhm.
traumatic because you have the light, and if there's lights in a medical setting, you're often laying down, and you're laying down when you're having these examinations, and so even something like that can be really dysregulating for someone who has fertility
Absolutely. I
trauma.
think that's a good reminder that, you go through it one time, then you're going to go through it, go through it again. You've got to go through the same experiences and same things being
Yeah,
triggered and brought
yeah,
back up. And trauma gets locked in our neural network, doesn't it? Those things
yeah,
get stuck there, and the body remembers, as
yeah.
well
The
as the
body
mind.
keeps the score.
Body
Yeah.
keeps the score. Absolutely.
And it's important to recognize that these aren't just easy appointments. These are appointments where you're naked and
Yes,
someone is doing a very vulnerable examination.
you
And so
bet.
you're very physically vulnerable in
You
addition to
bet.
very emotionally vulnerable. And this brings up like the challenge of lack of trauma informed care in medical systems, of like you're going in not only having to deal with that, but often someone not acknowledging the loss or saying things that are really hurtful or dismissive. And so it's really, really tough to go back into these situations.
That would be an interesting show at some point, to come back and talk to kind of our medical colleagues about trauma informed care. I used to do a number of talks when I was working in a hospital
Yeah.
with physicians about ways to relationally connect first, and then to
Yeah.
build whatever medically things they had to address. But that's such an
Right.
important cornerstone. And when that cornerstone's not there, oftentimes the
Yeah.
physicians wanting to be positive, or maybe not kind of wanting to
Yeah.
go down that path
Yeah.
emotionally because they don't know what to do with it if it opens up, they stay
Yeah.
kind of sterile and hygienic, and it misses a great opportunity. I'd love to just kind of flag that for down the road, you and I.
Yeah. I
to
would
talk
love
about
to come
how,
back if you did like
yeah,
a panel with doctors, because this is
yeah,
a big part of my work. I don't just do therapy. I'm
hmm,
talking to your doctor. I'm doing
yeah,
case management. Most people are coming in and they say, I need a new OBGYN. This one wasn't supportive, or they said this, or they didn't say this. And so when I get the doctor on the phone, I'm like, use me as a tool,
that's
because
so good.
I feel for them. Like they're not therapists. And I do
No,
think while it would be great if they had a little bit of like the training, it's
hmm,
really an unfair expectation to place on them. They
hmm,
also don't get an hour with each person like we do. They get
hmm,
15 minutes. A good doctor who can kind of bend the rules a little bit, who's trauma informed, will give more time in situations
hmm,
like these. But they don't have the training that we have. I mean, I have a lot of friends that are doctors and we talk about this all the time. And I ask them, what mental health training did you get in school?
hmm,
And the answer is always nothing.
right,
A round of psychiatry in the
right,
hospital. Like
exactly.
they don't get it. They don't know how to interact with patients. And it's really simple things. Like if I can tell a doctor, ask the baby's name, or just go in and say, this is so awful. If I can give them
Mhm.
just like
Just a
a
few
simple
little,
few word
that's right.
phrase,
All right,
here's what would be helpful. Don't put them in an exam room full of baby photos.
right.
Read the chart before you walk in so someone doesn't go in and say congratulations, or so they're not asked 10 times, why are you here, when they're there for, to check again because they know there
Mhm.
wasn't a heartbeat. Like very simple things, like the things that are free that cost nothing but mean everything.
Yeah,
Then like that patient's going to go in and have a way better experience, and that doctor is going to use that when they meet with other patients.
it's really good. Really good. I think that's
Yeah.
where we get to kind of equip some of our medical colleagues, and they have great hearts
Yeah.
and they have great intentions and they're bright and they're doing right things. But adding that relational component can make all the difference in the world, particularly around this area where there's trauma just
Yeah.
surrounding it. And so, I love the idea too. I want our listeners to kind of pick that up, that one of the things you do is you are in contact with
Yeah.
your patients, physicians, and kind of
Yeah.
doing kind of a team care approach, which I really love. Let's talk about, some of the places where couples might get stuck or they're
Yeah.
particularly just really struggling. How do you
Yeah.
enter and how do you help work them through exercises, approaches, techniques? What are you doing when someone is really struggling? And maybe kind of pick an example
Yeah.
and walk us through it.
With a couple specifically, or with an
Sure.
individual?
Let's,
Yeah.
yeah, whatever comes to mind.
Yeah. I mean, I think like the biggest thing with a couple is like the communication. Like I see that for every couple, and it's true in trauma and grief, of like going in and acknowledging that each person is going to have a different experience and that that's okay. The key thing is that we can't expect our partner to have the same experience as us, but we also can't expect that we then don't meet their individual needs. And so being able to help them advocate for and recognize, like, what do I need from you? And what do you need from me? Knowing that that might be different.
So just
And
as a start, if
so,
I could just jump in on that. So
yeah,
just as a
sorry, go
start,
ahead.
no. I don't mean to interrupt, but I just kind of want to frame something first. You're going into two steps. The first step is I want to kind of
Yeah.
psychoeducate them
Yeah. Yeah.
in the idea that we're going to have different experiences,
Yeah.
same moment, different experiences in it, same
Yep.
journey, but it's a different journey that we're each going to have uniquely.
Yeah.
And that's a normal and okay thing. And then you're taking it
Yeah.
a wee bit deeper and you're saying,
Yeah.
let's start talking about your journey and how they're
Yeah.
uniquely going on. Take me into that
Yes.
part.
Yeah, you're right. I did jump ahead. So that
It's
is
all
the
good.
processing of the experience, right? Like what's coming up for you? Where do you feel it in your body? What are the emotions? What's going on for you in your head? What are the thoughts? Oftentimes it's things like, my body failed, for the person who's
Yes.
carrying, if we're talking pregnancy loss or infertility, for the person whose body is, my body failed, or I failed you. I can't give you a child. For the
Mm,
other person, it's often things like, um, all I'm trying to think of like what is usually for the other person. I don't even want to talk about this. I don't want to upset you. That's a
right.
really common one. If I bring this up, you're going to be upset. And the other person's like, I want to talk about it. I want to know that I'm not alone in feeling this.
Right.
Because what
Right.
happens with that discrepancy that we talked about is then one party feels like, okay, I'm messed up. I'm fucked up.
Right.
It's me. I'm the
Right.
problem.
Yeah.
My curse here. Okay.
It's all
I'm
good.
messed up. And this person's fine. And
Yeah.
now the expectation is that I get on their same playing lane or their field, right? And I need
Yeah.
to be fine. And that creates a really big problem because now neither person's needs are met. So that's the
Mhm.
processing, kind of like an
I'm
overview.
imagining as we're having this talk today, for those that get to watch this, you'll see Tracy's office here. Those that are listening, let me just kind of create a vision for you. This is a very inviting office you're sitting in right now. And I'm imagining, as you got that couple on that couch behind you, you sometimes in helping them individually begin to kind of discover within themselves, maybe even explore within themselves, the very things you're describing right here. What am I feeling? Where did I carry it in my body? What's going on?
Yeah.
What are my thoughts, feelings, needs, hopes, fears,
Yeah.
all those things?
Yeah.
It's very hard for couples to turn and face each other in the beginning of therapy sometimes, just say, hey, let me tell you what's going on. And I can imagine you kind of getting your chair and kind of going knee to knee and just kind of going face to face with one of them and kind of holding that while their partner listens and kind of goes, oh, I didn't even know that. And then kind of stopping and holding that piece and then going to the other couple and saying, hey, what's that like to hear?
Yeah,
What
what
comes
comes
up
up
for
for
you as
you
you
when
hear?
you hear
Yeah,
that?
tell me about that. Yeah, exactly.
Yeah. I mean, yeah, exactly. I mean, using my body as a tool, right? Like my body language, like am I leaning in, my affect, mirroring, like mirrored, what I would call mirrored attunement, reflecting back like what they're saying. So if I see pain on the face, I'm mirroring pain, right?
You can't
And
help but not feel that too.
yeah, I mean,
Yeah,
it's
absolutely. You're holding that with
uncomfortable.
them.
Yeah.
Absolutely.
100%. I mean, it's a sacred space. Like when you're in it, you're in it. I mean, I cry with people when they cry. I mean, it's really such like a tender specialty because I mean, it's babies and it's people's lives. It's like what people imagine, and then it goes the complete opposite direction. It's relationship at every level, and it's like they often talk through the therapist, and so it's saying like
Yes.
I pause people and say, I'm going to ask you to do something that's going to feel uncomfortable. I want you to repeat everything that you just said, but I don't want you to look at me. I want you to look at your partner.
Very good.
And if it feels right, hold their hand
Yeah.
or put your arm on their back. And sometimes like when someone's sharing something really vulnerable, I'll stop and say, what do you need from your partner? I'm say, I want them to rub my back, or
So
I
good.
want them, you know, things like that. And so really
Yes.
like keying into the body language and having them not talk through me, and then slowing them down, because sometimes people will go very quickly and I have to pause and be like, hold on 1 second, this is really big, let's sit with this for a minute. And then going into,
Yeah, so good.
what is it like to hear? And then a lot of times people are like, I had no idea. And they can kind of come in and like correct that narrative. If someone's saying, I failed you, the partner can come in and say, you're not a failure, I don't blame you. And so like it's like, oh, like that's the work, you know.
Guys, got folks that are listening and just as you and I are talking, Tracy, that is the work right there. That is just a lovely description of what gets to happen in that sacred space that invites people to come in. You know, you're saying earlier that when we begin to share ourselves, there's a desire to be known. A colleague and I do a lot of couples work, refer to it as knownness. That's one of our greatest needs, to be known. And that knownness comes from, at its best, vulnerability, the ability to transparently and candidly and honestly, vulnerably share ourselves. But it is such a scary thing. I don't know how you're going to respond. I don't know if what I share with you is going to burden you. I don't know if I'm allowed to say that. All those things come into play. But what I love that you're doing is you're so present with those that are sitting on your couch right behind you there, and inviting them into that vulnerable space so that knownness grows. And what comes from that is that shared understanding, and out of understanding comes empathy. And out of that empathy comes this connectedness and a depth of growth that people so long for, but oftentimes really don't know that they long for it as deeply as they do. And then when they begin to experience it with you, I would imagine you see some beautiful things emerge on that couch right there behind you.
Yeah. And I think what you're describing is really the therapeutic relationship. Like, what is our job as a therapist? It is to see people, to know them, to allow, to create a space where they can be who they are. And it doesn't matter if it's not what we're supposed to do or say. And I always tell people, because I feel like we have weird jobs and people come in and they want to like win therapy, or like they want to get an A+. And I tend to attract like high achievers. Like this is the population. It's the people that are like at the top of their careers, they're doing well, and then for the first time, it doesn't go well with fertility. And that is like just like such a mind fuck for them. They're like, but I did everything. I did everything I was supposed to do.
Right.
You
And it's
know,
supposed to
and
go a certain way now.
yeah, and it's supposed to go a certain way. And so they come into therapy of like, tell me how long I'm going to grieve for. Tell me what I need to do. Like, well, I want you to like me. It's this whole thing. And,
Mhm.
I wait for the rapport to build a little bit. And then I like to tell people, I like to say, like, listen, like, I love and care about you. And there's nothing that you could say to me that I haven't heard before, probably have experienced myself, or would make me think any differently about you. And if you're not sharing honestly about what's going on, about those dark thoughts, or about the things that you feel like you can't say, I can't help you. I can only help what I know. And that is always like the moment for people where they're like, oh my, like, okay. And then we can kind of like break through that barrier. And it's that authenticity that leads to what you're
Mhm.
talking about of feeling known and feeling understood. And it's really fascinating because if you ask people, what is the most important human emotional need? Like, what do people usually say? Love. I want to feel love. And
Yes.
that's not the most important need. According to research, is what you're talking about. It's to feel known, to feel understood, which leads us to feel loved.
Absolutely. And if you love me and you can hold that space with and for me, I'm going to
Yeah.
feel so loved beyond words.
Yeah.
And there's something so intimate about that and so connecting around the effort being made to understand each other and know. And that knownness, you're right. That's
Yeah.
that's the precursor to the love that we seek so deeply with each other.
Yeah.
Where I was kind of framing it as, techniques and approaches and exercises. And there's some great communication strategies out there. And there's a connections code book. There's the NVC, nonviolent
Mhm.
communication. These are some really
Yeah.
great techniques and
Yeah.
approaches. But what I want our listeners to understand most is that in that sacred space, in this sacred space of therapy,
Mhm.
a lot of it gets to take place in the moment, doesn't it? It's
Yeah.
that willingness on the therapist's part to want
Yeah.
and being able to lean into and invite
Yeah.
kind of that first the knownness that takes place with the patient themselves. I guess to say,
Yeah.
let's know you a little bit better, and let's you and I kind of discover and kind of mine down into that. And as that knownness for themselves evolves, kind of
Mhm.
through that organic process of you just leaning in, mirroring, and,
Mhm.
and genuinely loving them in that process,
Yeah.
some really cool things emerge. What are you thinking?
Yes. No, I'm just thinking like on that note, like when people are scared to like show who they are, to be vulnerable,
Yeah.
I like to always ask the question, and you can use this question and adapt it for any intervention or any population of when someone shares something that they're scared to share, like, oh, like, oh my gosh, like I'm having a hard time, or like, I don't want to be having a hard time, right? Or like, I don't want to say that I'm depressed. I always like to say, well, what would it mean if that were true? What would it mean about you if you were depressed? What would it mean about you if you were having a hard time? What would it mean about
Mhm.
you if you couldn't get pregnant? What would it mean about you if you did fail your partner?
Oh
Like
man.
I like to just like go there because
You're
then
just
it's
dropping
like,
them right down into their greatest fears,
yeah, what would
biggest
it
hopes.
mean? Yeah.
Mhm.
And then I can come in and reframe that for them,
Yeah.
you know, based on what their response is. I can say, but everybody feels depressed. I can say things like, of course you're depressed. Your baby died. I would be worried if you weren't depressed. It would
Mhm.
be weird if you came in here and said everything was fine. I would think, oh my gosh, this person's really disconnected. So it's things like that.
I think that's such a beautiful process. When you're talking about people are scared to be vulnerable, there's all kinds of reasons for that, whether it's, our families of origin or past relationship dynamics or um, what might it mean about me? Like you said, there's some high achievers coming into your practice, and those are those that basically through their own merit say, if I do this, this is going to happen, right? And there's the first time in my life, maybe when I've done this, this isn't happening. And so what does that reflect and say about me? So that vulnerability is a scary thing. And what I
Hmm.
love about therapy is that that therapeutic relationship in and of itself, just
Hmm.
that,
Hmm.
there are wonderful opportunities for what we refer to as corrective emotional experiences, where someone's
Yeah.
paradigm is this: if I don't do this, then I'm a failure. And what the therapist and
Yeah.
what you're describing very clearly gets to do is to say, no, it's not
Hmm.
true. You get to expand that definition or that understanding and say, that's not what it means at all. And someone that maybe for the very first time says, really? Are you
Right.
serious? And in that moment, something
Yeah.
begins to change, and you can hold those fears, those hopes, that self-perception, whatever it may be, in that vulnerable
Hmm.
space, and allow that corrective emotional experience because of the way you're showing up and holding that. And then what you do is, I think, is a really cool thing, is then you give it back to the couple. And I believe our relationships are, I think there's a divine design in them, but I think there are core needs that we don't have met that get to be met in therapy, not just from the therapist, but in the couple themselves, where they get to have a corrective experience, a corrective emotional experience, where their partner is showing up in ways that no one has ever shown up for them before. And they so want to have someone do that, but they may not know how to do it. And you're facilitating that.
Yeah, and I think that's what we do as therapists. You know, my favorite thing that I've heard someone, like, favorite way that I've heard someone describe our job is to love people. And it's
Yes.
one of my best friends who's a therapist, and she got asked this question of like, how did you know you wanted to be a therapist? And she said, well, I knew that I just wanted to love people. Like, I wanted that to be my job, you know? And it's like, the therapeutic relationship is the most valuable tool. We know that. It's the most important factor in determining mental health outcomes.
Yeah.
Which, going back to just one note on the trauma-informed care, which is why it blows my mind that that's not emphasized, because that is gold. That is the thing,
It's
right? And so it's like we are healing and repairing attachment wounds through our relationship and our work with people, which they then have a reparative experience and take that, and then they can heal outside relationships. Like,
You bet.
we are modeling how to have that, not only in our interactions with them by like what you said, facilitating amongst each other if it's relational work, but then they have that positive experience. What do they learn? They learned, I can say something that I don't even want to admit to myself, and I don't feel like bad about it. I feel actually better about it.
All right.
And I can
And
do
the
that
self
on the outside.
expands in that moment, doesn't it? The self begins to expand. You're saying that that expanded self gets to come into other areas of their life as well.
Yeah.
Listeners, those are some good nuggets right there. Grab those and put those on the hearth or put those on the refrigerator. Those are great things you're saying right there, of how that gets to be in the therapy itself with a couple on your couch, and then it gets to come into the other areas of their lives as well. Talk about some of the, well, let's get a little more specific around that. And what are folks experiencing in them, individually with you, as a couple with you? What do you see growing and changing, and kind of some markers of improvement?
I think, like, the biggest thing that I see, well, first of all, if we're talking grief, I know I'm using that as a primary example, but that seems like the one to stick with. If we're talking grief, one of the biggest things is people come in, having an idea of how grief looks, because we're not educated on grief properly, even in mental health. What do most people say when you say, tell me what you know about grief? They say the 5 stages of grief. No, it wasn't even meant for people who are grieving. It was meant for people who were dying. And even the founder of that came out and said, don't use that for, it's antiquated. It's not, but that's how people look at it. They look at it as staged. You grieve for a period of time. Usually they think that to be days, weeks, months, maybe, and then you're over it. And that's not true. So one of the biggest markers of improvement, I think, is I'm leading people to lean into the discomfort of grief, which is a very different type of therapy. Whereas if someone's coming for depression or anxiety, like, of course I want them to feel, but I want to minimize, I want to decrease those symptoms. With grief, I actually want them to feel it more, because I know that the only way to move through grief is to grieve, and that you can't avoid it.
That's
and
the
so
path.
one of the markers is well, it's starting with the education. It's like I was saying, someone's coming saying, it's been 2 weeks, I should be over it. And I'm like, you don't ever have to get over it. Your relationship to it will change. It's not always going to feel as raw. You will move forward because that's life and you don't have a choice, but there's a difference between moving forward and moving on. And so when they can lean into the grief and process, and then they can cry when they need to cry, and they can go out of work, and they can say no to things, they can fall apart. Then they get to the coming back together piece, and the functioning, and learning how to move forward. And that is one of the biggest markers for me, is taking them through that. And it's painful as a therapist. I mean, it is. You come to session and people are just crying the whole time, and it's like you just want to, like, hug them and be like, this is so awful. And you're just saying to them, this is so awful, and there's nothing that I could say to you that would make this less painful, and I wish I could give you that, and I can't. And so it's, taking them through that. It's having them talk about, and this is true for all grief therapy, the person who has died, and asking questions that people, don't usually get to answer or get to talk about. And so for me, taking them through that, the marker then, after some work is being able to honor that person or that baby, and being able to grieve appropriately and lean into it and not judge themselves for their feelings, and also move forward and figuring out how does moving forward look for them.
You know, you're saying that the path through grief is to lean into the grief and just immerse ourselves in it, trusting that as you join them in that, right things are going to naturally happen. It just does. It's how we're wired. And what I'm seeing is maybe some of the markers that we can highlight is just the freed upness to just express whatever's there whenever they need to do it, and to have somebody sit with them. It's you, maybe their partner sitting next to them, and just to join them in that and not have to be alone in it. That's a huge thing.
It's the biggest thing. It's really the only thing with grief is to be a witness. It's the best gift that you can give a griever, is to bear witness to their pain, because the thing about grief is you can't fix it. Like, you can't. The only thing that would make someone feel better would be for their person to be alive. That is the fix for grief, which obviously we can't do. So what can we do? We can support them. We can let them know it's okay to talk about it. We can help them to explore boundaries. We can help them to give feedback, to advocate for their needs with supports. We can help them to say, you know, it's okay to say no. You don't have to go to that baby shower. You don't have to go to that kid's birthday party if you don't want to. And that doesn't mean that you don't love that kid or that person. It doesn't make you a bad friend.
No.
You know, and so it's helping them through that process.
You're really right-sizing some things for them there. And I can see how when they are freer and freer and more trusting in their ability to sit with, and that it's okay to do so with the grief and the loss, the mourning, how then it begins to kind of move to a place of honoring, you know, the loss themselves, probably bringing the couple closer together. And also, I would imagine that's where it begins to emerge of, where do we want to go now? What's going to be our next kind of our less judgment, and also what are we going to do to move through? Really good.
Yeah.
Hey, you know, I know we're kind of coming to the end of our time, but I want to ask if you leave our listeners with kind of a takeaway message of hope. And I mean, this whole podcast today has been about hope and how we can go through these things and what it looks like when you do. And it's such an inviting message, and it's real and it works. It sounds kind of funny, but this really is what therapy looks like and how it really works best. But leave our listeners today kind of with a message and a takeaway that you'd like them to have.
Yeah, I think the takeaway for me is always that whatever it is that you're going through, even if what you're going through isn't on par with what we're talking about, is valid and normal, and you're not the only one, and you don't have to go at it alone. There is support. And even in the situation of grief where nobody can fix it for you, it doesn't mean that you don't deserve support, and that we can aid the suffering, right? It's like the difference between pain and suffering. We can't take the pain away. We can support the suffering. I can't erase the pain for people. I can walk alongside you. You don't have to do it alone. And so being able to see yourself as worthy of that support, and to break down any stigma surrounding like what it means to get therapy, or what it means to fall apart, or what it means to be a person who needs that. You know, I think we're coming, like, there's a good new wave where mental health is in the last couple of years more talked about, but it's still very stigmatized. And so I think we're making a lot of, you know, progress there, but really just knowing that, you know, pretty much everyone needs therapy.
Yes.
And
what a great resource to be able to have access to.
And
why not take care of that part of our health?
And doesn't mean anything about you, and good for you for leading into that and for getting the support. And the little bit of hope that I always throw in there, and this is what I tell people who come to me, I say, you're not going to ever get over it, and that you're going to arrive at a point in which you'll be like, totally cool that horrible thing happened to me. And over time, it will lift, your relationship to it will change, and you will figure out how to move forward. It won't always feel this way. It won't always feel so heavy. And I like to tell people, I'm like, if that were true, anytime something bad happened to someone, people would just give up. People would never go back to work. They would never get out of bed. They would never go to the grocery store. And that's it. Right. And people are always like, okay, you promise I won't feel this way forever. I'm like, yes, you won't feel this exact way forever. And you will find a way to incorporate this into the fabric of your life and how you live it.
It's really good. That's a great word as a takeaway here. Thanks for that. Hey, as we wind down today, give us some resources. How do we find out about you, of your services? You guys have got a great website, some awesome services being offered. Tell us about that.
Yeah. So I have honestly a lot of resources on my website, which is just the
Mhm.
name of the practice,
Yeah,
tgntherapy.com. I have an Instagram account, which is grief, perinatal, reproductive, infertility, focused. And I'm interactive on there. Like I do polls and, I share things that people send me and stuff like that. But lots of articles, podcasts, other Instagram accounts. So I would say website's kind of the best way.
that's
Best
really
way to find
good.
that stuff. Yeah.
Yeah,
Most
I
of
was
it
just
all.
on it. I was on it quite a bit this week, and there's a really cool resources on there. It's nicely laid out. It's beautiful, and
Thank you.
some really good things you guys provide just for people to take have a look through and just kind of peruse through and enjoy. So, well,
Yeah.
Tracy, thank you so much for today. It was great to have you back, and what an awesome show. Thank you so very much for being with us.
Yeah. Thank you. I appreciate it. It's fun to be here.
Great to have you here. I also want to thank you, our listeners, for joining Tracy and me today. It's always great to have you with us as well. I want to remind you that this episode and its resources and all of our other shows can be found on our webpage at triadhq.com/BHT. So go check it out, our webpage, triadhq.com/BHT, and explore our archive of podcasts and resource materials. Thanks so much again for being with us on the show, and we'll look forward to having you back with us next time on Behavioral Health Today.